This is, of course, Dr. Anthony Fauci, Director of the National Institute for Allergy and Infectious Disease. For many, he's become the public face of the federal response to this pandemic, but his institute also played a really key role in developing one of the first approved vaccines, which he got today. So how are you feeling after that?
I'm feeling fine. I'm actually feeling quite good. Nothing remarkable. Don't even yet have a pain in my arm, where that usually occurs a few hours later, maybe later on in the day. But right now, physically, I feel really quite good.
That's great. So you said, there could be pain later. Any others you could be expecting? Any other side effects?
The standard type of reactogenicity that they call it varies from person to person. You get some soreness at the site. You get maybe some muscle aches, maybe a little chill, feeling a little bit almost flu-like. That usually lasts for 24 to 36 hours, and then it goes away. Some people get fever, not a large percentage, but some do. And all of that it can be self-resolving or even helped out with some Tylenol or something that you would do to just prevent it. But other than that, most people just do fine.
Great. So I've gotten a lot of questions from people about, if I get the vaccine, why can't we stop wearing masks? Why can't we stop social distancing? Why can't we go back to normal yet? And when do you think there is going to be some semblance of normal?
Well, I think it's going to really depend on what proportion of the population ultimately gets vaccinated. We're hoping that anywhere from 70 to 85% of the people in the country get vaccinated, because that would create kind of an umbrella of protection over the country, that what we generally refer to as herd immunity. And until then, you don't want to abandon public health measures. I mean, that would really not be a good idea, because there still is now, even though people are getting vaccinated, there are still an extraordinary amount of virus in the community. I mean, if you look just to yesterday, another record was broken with 118,000 hospitalizations. The deaths are between 2,000 and 3,000 a day. The number of new cases are hovering around 200,000 per day. We shouldn't think of the vaccine as a substitute for public health measures, more complementing public health measures. When we get to the point where we brought the level of virus in the community so low that it isn't a threat anymore, then we could start thinking of backing off a little bit on some of the stringency of the public health measures. That will be gradual. That's not going to be for several months until we get what I would consider the overwhelming proportion of the population vaccinated.
I do want to get to what you talked about with record new highs, but first, before that, there was news this week out of the United Kingdom that there's a strain of the coronavirus that is more transmissible. What could be the impact there with the vaccines, if any? Are they still effective against the virus? And what do we know so far about that strain?
Well, it's being actively studied. We're going to get the strain here and study it in our own group, as well as Walter Reed will be studying it. The CDC will be studying it. So here's what I think people need to understand, is that this virus is an RNA virus, and therefore it will mutate. RNA viruses love to mutate. That's their occupation. So they make a living by mutating. Most of the mutations are not of any functional significance or consequence, but sometimes a mutation occurs that changes the function of the virus. It is suspected, not yet proven, but it is suspected that this is associated and has caused a greater efficiency of transmissibility. It could be something else. It could be a super spreader event and not inherently more transmissible, but some of the experiments in vitro in the test tube indicate that it might be. So let's assume that it's more transmissible. There is no evidence that it increases the virulence or the seriousness of the infection. And there certainly is no evidence that it evades the protection that is induced by a vaccine. So far, so good on that. But we're going to keep watching it really very carefully. But from the information we have right now, this does not make the vaccines that we're using any much of a problem at all.
Mm-hmm. And these are not, like you said, this is what these viruses do. So this is not even the first new strain that we've found, right?
Oh, no, not at all. We had another mutation, the D to 614 to G, that seemed to be associated with an increased transmission. But even now, months later after the discovery of it, we're still not sure if it just evolved naturally and took over as the most dominant strain, or if it does increase transmissibility. That was the one that happened months ago. So what you need to do is keep your eye out on these types of mutations and take them seriously. Don't blow them off. Take them seriously. And if you show that there's not any relevant functional change, fine. If there is, then you try to address it.
Got it. So switching gears a bit, President-elect Joe Biden is set to assume office in less than a month. So how does that impact vaccine distribution, or just kind of where we are right now with vaccine progress and the pandemic response?
You know, it doesn't really make any major change because the contracts for the procurement and delivery of doses of vaccines have been made some time ago. So they're either on schedule or not. I don't think you can do much, except one of the things that we were discussing about this was the possibility of adding some resources to get the distribution at the local level a bit more efficient. That is one of the things that I think that President-elect Biden will try to do.
Mm-hmm. And have you been in talks with Biden's team about this and ensuring a smooth transition through, like you said, a really critical time in terms of new case counts and the progress that we could be making, but also the harm that can still be done?
Yes, I have been in contact with the Biden people, including the president-elect himself.
Mm-hmm. And do you think that they're going to be switching up the way that they're dealing with this, or is it going to be primarily a smooth transition?
Well, I hope it's a smooth transition. I hope that we get a chance to more openly discuss matters with them. So far, it's certainly better than it was in the beginning. We are engaged in conversations with the transition team.
So this is a question that I've gotten from a few viewers and some scientists I've been speaking to. Do you think that the vaccines are going to make a substantial impact on transmission, and when might we see that?
Well, we know as a fact that these vaccines, both the Moderna and the Pfizer vaccine, are extraordinarily efficacious in preventing clinical disease. They're also very, very efficacious in preventing severe disease. What we don't know for sure yet is whether it prevents actual infection. In other words, we know that people don't get clinical disease. There are some that might get infected but don't get clinical disease. We're going to be able to find that out as we follow these people over the next several months. So that we're going to have to leave that question unanswered now. We don't know whether it prevents just infection. We know for sure it prevents clinical recognizable disease.
So I'm pulling up this question right now from H. Sanders 528 because I've gotten a form of this question from people who've had COVID before, from people who are immunosuppressed because of medication or another condition, and from people who have serious allergies. So all people asking, should I be getting the vaccine or should I wait? So first, should people who have had the virus before get it, but then those other groups as well, are there people who should be waiting?
Well, if you've been infected, you likely have some immunity. The question is, what is the duration of that immunity? So ultimately, it is going to be recommended that even if you have been formally infected, that you should likely nonetheless get the vaccine when it becomes available to you. You may not want to be the high priority person, but sooner or later, you should get vaccinated even if you've been infected, because the duration of the immunity following infection is unclear.
Mm-hmm. And what about for people who are immunosuppressed or people with allergies? Is there anybody who should not be getting the vaccines right now from what we have
Well,
available?
well, you've got to separate immunosuppressed people from allergic, because allergic people have a hyperactivity inappropriately of their immune system, and people who are immunosuppressed have an underactivity, probably because of drugs that they're getting for cancer or for autoimmune diseases. There's no contraindication for people who are immunosuppressed to get vaccinated. The vaccine might not be as effective because the immunosuppression is suppressing the immune system, which is the rationale for the vaccine, to stimulate the immune system to make a protective response. So you separate that from allergies. If you have an allergy, if you are someone who's had a serious anaphylactic type reaction, the recommendation is that if you get the vaccine, you do it in a location that has the capability of treating you if you have an allergic reaction. If you had a allergic reaction to any of the components in the vaccine, and the FDA lists what they are, then you should not get vaccinated. But if you have allergy to food or allergy to an antibiotic or something, you could still get the vaccine. But you've got to be careful to make sure you do it in a place where they can treat you if you get an allergic response.
Right. This question reflects a lot of people asking what you're going to do to face doubts and people who have vaccine hesitancy. So Jose asks, why should we trust this vaccine if we don't know the long-term effects it may have?
Well, if you look at what you mean by long-term effects, there are very few situations, if at all, in which you get vaccinated today and you have a long-term effect that you notice 2 years from now. I mean, you could get a long-term effect that's a serious adverse event that might last for a long time. But it was extremely unusual that you get vaccinated today and you have the onset of an adverse event a long time from now. So what the FDA has done is that they've looked at the adverse events associated with essentially all vaccines that have been given historically. And the overwhelming majority, probably 90 to 95% of them, occur within 30 to 45 days after receiving the vaccine. And that's the reason why, baked into the process of the emergency use authorization, is that the FDA will not issue an EUA until 60 days after half of the population who's been vaccinated gets their last dose. So already you are beyond the time when the overwhelming majority of adverse events that are beyond just the first day or two occur.
Mm-hmm. So for those of you just joining us, we're with Dr. Anthony Fauci, who practically needs no introduction, but a lot of people are still asking about the UK strain of the virus and if the vaccines will be effective. So I just wanted to bring up again that we talked about that with Dr. Fauci earlier, and he said that it's unlikely because there are often, or it's unlikely it won't be effective because there are often new strains. Just wanted to highlight that. But another question that we got was someone saying, are you more worried about this new UK strain or the allergic reactions that people could be having to the vaccines?
You know, first of all, I don't worry about these things. So I'm not worried about either of them. I pay attention to both of them. And as I said before, you can do something about each of those. With allergic reactions, we're starting a study here at NIH to determine what the frequency or incidence of these reactions are and what they are associated with. Are they more associated with food allergies, with antibiotic allergies, with allergies to other products? So the better we understand them, the more we can both prevent and treat them. With regard to the mutation, as I mentioned to you, Sarah, just a little bit ago, it is very unlikely that this is going to have any impact whatsoever on vaccines, because when you vaccinate somebody, you make polyclonal antibodies against multiple parts of the spike protein. A mutation is one point mutation, so that if it's mutated here and you have a single antibody, like a monoclonal antibody, that unluckily happens to bind to this, then this antibody is no longer good. But when you vaccinate somebody, you make a whole host of antibodies to all parts of the viral protein. That's the reason why it is unlikely, not impossible, but very unlikely that any point mutation is going to completely obviate the efficacy of a vaccine.
I'm pulling up this one now. When would the vaccine be available to people under 16, and how safe would it be for infants? And I want to add to that one, there haven't been studies so far yet in anyone under 12 years old, but how necessary is it to give the coronavirus vaccine to infants if we concentrate on the adult population first?
Well, what we do, and this is not peculiar for COVID-19, this is what we do with all vaccines. You first test them for safety and efficacy in very many adults. In this case, the Pfizer had 44,000 people in the trial. The Moderna had 30,000 people in the trial. Once you show it's safe and effective in the population that are the adults, because children are vulnerable, particularly the younger children who have no way of giving informed consent, you've got to be very careful about safety. Safety is paramount. You want to balance the need to protect the children by vaccinating them with the risk of the vulnerability of the child to something going wrong with the vaccine. So what you do is that you usually wait a few months, 1 or 2 months, after the vaccine for adults has been out there, and you get a lot more data as to safety and efficacy. And then you start vaccinating children in what's called a phase 1 or 2A trial, where you don't need 10, 20, 30,000 kids. You need maybe 2 or 3,000 to show two things. Is it safe? And does it induce the kind of immune response that's comparable to the adult response, which actually protects you against disease? If those responses are comparable, you can do what's called a bridge. You can bridge the data of safety and immunogenicity from the pediatric study to the efficacy of the study that you did in adults. The bottom line answer to the question of the person who wrote that in is that we will have a vaccine to be able to give to children a few months beyond the time that it is approved for the adult.
Great. We're running out of time, but I'm going to squeeze in 2 more questions if I can. I found this one to be really interesting. Will we ever be rid of COVID-19 and other coronaviruses? I recall you saying once early on in this that coronaviruses could be our new normal.
The answer is we will never eradicate coronaviruses. One, they're very transmissible and they're widespread. Number 2, they have a reservoir in animals. This coronavirus that we're dealing with now came from a bat reservoir to likely a secondary intermediate host to a human. I believe we can control and even eliminate certain coronaviruses with a vaccine. I doubt if we will ever eradicate coronaviruses. We've only eradicated one human infection in all of history, and that is smallpox. We've controlled others, we've eliminated some, but we've only eradicated one.
Incredible. So the last one I want to ask, this one comes from me. When we spoke in early March, when it was days after the first reported deaths in the US from the coronavirus, it was before the stay-at-home orders, you said, quote, "I don't think we are going to get out of this completely unscathed. I think that this is going to be one of those things we look back on and say, boy, that was bad." So what were you thinking about when you said that? And is that where we are now, or could it have been different?
Well, I guess unfortunately I was prescient when I spoke to you,
Yes.
and very unfortunately that I was. Um, it is really a historic outbreak. I'm not sure exactly. There are so many things that you can say could have been done differently. Would we be any better off than we are right now? Likely, but retrospective scopes are pretty easy things to look through. I think the way we need to look at it now is to look forward. How are we going to get out of this? And I might say that public health measures will keep us controlled until virus gets suppressed by vaccine. When vaccine takes over, that's the game changer. And that's something that will likely, now that we have very effective vaccines, the real challenge is to get as many people as possible vaccinated. That's what we have to do. Once we do that, the light at the end of the tunnel is going to get brighter and brighter and brighter until we're going to see, sunshine without a coronavirus.
When do you think that sunshine could happen if you had to guess?
Well, if we are effective in getting the vast majority, I'd say anywhere from 70 to 85% of the population vaccinated, if we can get them vaccinated, then I think we can do that by the end of the second quarter, the beginning of the third quarter of the year. We can get back to some form of normality.
That's great. Something to look forward to. Well, thank you, Dr. Fauci, for being here, and thank you for all the viewers and all of the great questions. There were so many more I couldn't get to, but we appreciate your time. Thank you for coming.
Thank you for having me, Sarah. Appreciate it.